Now, we're now going to move on to the last debate of the morning. Assessment of healthcare professionals, what criteria, what dissemination? So Mathieu Durand, who is the founder and director of What's Up Doc, can you give us the results of a survey on young doctors? If you'd like to take the microphone, please. Yes, thank you, Guy. So according to a survey that was carried out by What's Up Doc, which is a magazine on young doctors, 82% of young doctors say that they know at least one doctor who they consider to be dangerous in the way they practice their profession. In 64% of cases, the problem comes from the choice of therapy, the choice of treatment, whether we're talking about the prescription of medications or an indication for some kind of technical activity. So according to surgeons, the problem comes from the quality of technical acts. So the question is, should we or should we not assess doctors? The question is not how can we use assessment to improve or update practices that are already considered as best practices? The real question that needs to be talked about is what are the criteria should be used for the assessment and how should we disseminate that so that we don't have dangerous practices that endanger people and doctors themselves. So may I call on Michael Benzaki, Xavier Catalino, Jens Dierberg-Wittram, Jean-Luc Arousseau, Sir John Took, and the debate will be moderated by our friend Francis Brunel. Thank you very much. Now, as it is 12 o'clock and you're all connected, you know that your blood sugar levels are low. So put your arms in the air, move around a bit, just to increase your blood sugar level. So hello, everybody. I simply wanted to give you a very short introduction because we've already set the scene thanks to the statistics provided. So assessing is all about assessing value, but the next question is, how do you assess value and what is the content behind that word? So this is not a new idea, assessing professionals. This is something that we've always been doing. It's allowed us to create a certain number of structures that you are familiar with. Today, pairing assessment of professionals and training, further training, FMC or whatever it is called in France or elsewhere, that's something that we're going to have to do. We're going to have to pair these off in the future. So to begin with, I'd like to use a photograph that was taken. This is a current affairs photo. This is the TripAdvisor of health. Perhaps you will be able to rent out your surgery, have some kind of Airbnb for medical purposes. So let's start the video before we ask the first question to Jean-Luc. If we can have the video, please.
Alors, comme je ne suis pas journaliste,
Now, as I'm not a journalist, I don't know what we should do to fill in this terrible silence. I don't have the weather forecast. There's no video. Okay, there's no video. That's a good explanation, a good technical explanation. So there's no video. Thank you. So Jean-Luc, so assessment. Why do we assess professionals? What do we have to assess? And the next question is, how do you assess? So what should we be assessing? I think that initially what we wanted to assess was the skills of professionals, of doctors. And this is already difficult to define. So a few years ago, we defined skills as, on the one hand, what had been acquired in terms of theory and practice, and ability to react to situations, on the other hand. So clearly, there's a relationship between individual skills and results. And it's especially in surgery that we have known for many times that there are great disparities between surgeons. that when you take 100 surgeons who create an adverse effect, 10 to 70% of these surgeons would make the same mistake in the future. So there is a problem of skills. Yet, I think that things are more complicated than that. It's not just a question of evaluating skills. In fact, we're not on our own. We all work in an environment, and we know that medical errors, unwanted effects, are often linked to the dysfunctioning of teams. Very often, these problems are linked to people not getting on with each other, not communicating. An Israeli study showed that when there are problems between doctors or doctors and other members of the team, the results are not as good. So it's not just a question of know-how, it's a question of knowing how to be, a question of behavior, a question of acting as team players. And at the Health Authority, we are focusing more and more on this teamwork and assessing teamwork. Xavier, you're a surgeon, and you buy into that. So it's individual, it's collective, or it's a process that you're assessing. So you've got to assess the collective. I'm sorry, there's a problem with the microphone. So that's better. So collective assessment is indispensable because we all work as teams, surgeons especially. So the assessment has to be collective, even if you can't get rid of individual relations. Let me just come back to why we assess people. That's the initial question. Why? Well, all activities have to be assessed, and there are a number of specific aspects relating to medicine. You've got to improve healthcare. It's all about public health. So it's obviously important. The objective is not to make sure that all doctors are excellent. There will always be good, very good doctors, and not as good doctors. The idea is that we don't want any deviating practices or results. And the second point, which is connected to the first, is that we've got to adapt and improve training, initial training and further training. And this means that universities and academics need to be involved. So since this morning, we've been saying that we've got to be careful not to confuse the tool and the objective. The assessment is a tool for a given objective, and we need collectively to be able to do this. This is something that we talked about with respect to the EMR. We need to know what is the objective of the assessment. Jeans, you are very attentive to the outcomes of healthcare systems. What is your opinion about the need to set up this tool? Why would we set it up? What is the objective of the assessment? And should this assessment tool be individual, collective? And at last, we'll have a discussion about, at what level do you carry out the assessment? As soon as people are studying medicine, and, should we be talking to our young doctors?
Yes, I think there are basically two objectives why we are assessing doctors or teams or hospitals. And one is, from my point of view, the more important one, that we need to improve care, because that was mentioned earlier. The main problem is we have huge variation in care practices. So not every doctor is doing the same, although some people believed that healthcare is pretty much standardized. And we have huge differences in outcomes. So the care results are simply very different. So number one for me would be we need to systematically improve. The second piece is there is the right for patients to take an informed decision on what kind of care provision they take. So I believe we should take that very seriously. If we know that there are some hospitals or doctors or teams who are performing subpar, we shall not hide this information to the patient. I believe that would be substantially unfair. But coming back to the improvement piece, the main problem is, from my point of view, we all know that there are many, many different factors who might influence the outcome of a certain medical procedure. And we have a lot of assumptions what is driving, better or worse care. The reality is we know relatively little about it. So you are an experienced surgeon. Imagine you are coming back from a 2.5-week summer vacations. the first day you are back in the OR, is the outcome you produce as good as the last day before the vacations? Is it better because you are so relaxed and you had huge amounts of wonderful wine and good food? Or is it worse because you lost experience? Will it be better if you have your most experienced nurse with you, or will it be better if you have a very, very keen apprentice with you? Will it be better when you do the surgery in the surgery 1 you are always using on Mondays, or in surgery number 3, and so on and so on? We have very little data.
Jens, don't tell me that you are in favor to suppress holidays and vacations.
No, what I want to foster is we seriously need to collect the outcomes that are achieved on a team level, on a physician level, or even on a hospital level, and we need to play this information back, because first of all we need to learn what is driving improvement, and then we have to apply that.
Thank you. Sir Tuk.
Thank you.
Why should we do evaluation of processes or professionals, and what is the probable outcome, and what tool do we have?
Well, I fundamentally agree with Jens that this is all about trying to improve healthcare quality and reduce the very considerable variation in outcomes that we see across the health system. I think it's worth, however, emphasising there are two important social drivers for this desire to see more assessment. The first is, that we've heard about earlier today, is the democratisation of knowledge. So citizens are much more aware of health and health consequences. And this has led to a growth in a consumerist attitude towards health. And if you're a consumer of anything, you want to be able to exercise choice. You can't exercise choice unless you know the value of the product that you're seeking to use. So that's one important factor. The second generic societal issue is that I think societies in general are becoming more risk averse. This is not just in the health field, we see it in the finance sector following the crash, we see it in relationship to the development of new medical products. Licensing and regulatory requirements are becoming far more intense. When you combine these two elements, you can see how society is demanding a much tighter system of assessment and statutory regulation to control it. And we can't fight this. I think it's happening. Of course, there is one unfortunate consequence of this, or potentially unfortunate consequence, and that is that if you try and ensure conformity, if you're not careful, you can stifle the very innovation that drives up the quality of healthcare that we all like to see. There was a notable comment made by one of our Secretaries of State who said in the UK Parliament, no doctor should be below average. Now, that's statistically quite difficult, but you can see some of the challenges if people don't understand that conformity is not as easy to achieve as we would like.
Merci beaucoup, John. Je crois qu'on devra effectivement, en fin de table ronde.
Thank you. I think at the end of the round table discussion, we will have to take into account the perverse effects of the assessment, because we all know here that every time we want to improve a system, every time we want to set up some kind of procedure, there are always these perverse effects. You've got the other side of the coin, right, in anything that we do as humans. Once again, it's the same for medicine, which is a human activity. Michael, what is your opinion? And without wanting to guide you, but let's look at this question again. You finished your studies not long ago. You were assessed every semester as a young aspiring doctor. There are two levels for the assessment, in fact. There's something specific to France. In France, you have the guillotine. So you arrive, you chop off heads. You've got your A-levels, you've got your O-levels. For doctors, you've got the first year. You get through your first year of medicine. You've got to get through to internship. And either your head is cut off or not. So that's very French. So from a very young age, we're afraid of this assessment. Now, the second point, and in Anglo-Saxon countries, it's more natural. It means that you can improve performance. Then you've got the generational aspect. This is something that we see. People are tweeting at the moment. It's something, we say like on Facebook. It's a bit like TripAdvisor. We're assessing all of the time. We even had a survey for assessing what we're doing here today. So it's natural for us to assess, to give our opinion, so that then we have a different kind of perception, so that we rectify things. Now, concerning assessment every semester, I'm sorry to say, we carried out a study at the intern union on theoretical information of interns, and it revealed that during that internship, 60% of interns were never assessed.
Yes, I hear a lot of murmurs behind my back. Yes, those murmurs. We're hearing them again. Yes. We published, to be provocative, we published this, but at a given moment, we are going to have to sit around the table and determine what is an intern in surgery. What should he know? Has he spent 5 years just holding the camera? So we need to decide how we assess people throughout their professional training, so that we ensure that then we have high-quality professionals that are much above the average, of course. Now, let me ask Jean-Luc again. Now, we all agree, I think, that indeed assessment is necessary. So, because it is a human activity, as we said earlier, people must want to act. You need to give them the desire to act. It shouldn't be a sanction. I think it's quite simple to put into place. And then the question is raised, just like the one we raised previously, what type of governance of this assessment? And what are the tools for this governance? Now, I turn to the HAS. You can freely comment here. That's the principle of SHAM, so you don't have to speak on behalf of the French Health Authority. But who should do it, in your opinion, and what should be the governance? How should we assess, with what tools and at what level? Well, if you're thinking that it's the French Health Authority that should do these assessments, well, we already do a lot. We are improving, of course. But I think in this case, we can't do everything. There are many other players involved, in particular the regional health agencies, the Doctors' Council of Order, the university. There are many players. Well, when there are too many pilots, often nobody wants to be the pilot, Jean-Luc. Well, perhaps we could coordinate, and maybe we need to work on this coordination, I agree. Now, you talked about assessment tools. Initially, we evaluated skills, I said, and I didn't have the time to say this, but I think our two guests said it beautifully, because they both work on the outcomes. I think increasingly today we're going to be assessing professionals in terms of their outcomes, and I think the professionals themselves are aware of this, and they agree, provided that it is really has a shared foundation of professional values. But increasingly, we will be focusing on outcome. I think that's clear. It's very difficult. How can you judge an outcome? Now, more and more, we will not be judging a single professional for his training or the way he attended congresses or how he filled out multiple choice questionnaires on a server. That will continue, but I think in addition, we will actually judge the professional in terms of his outcome. The Anglo-Saxons were the first to set up what they called indicators, and the French Health Authority has this mission to define the indicators. So perhaps there are too many indicators, perhaps they're too complicated, and above all, they often oblige us to look at patient files. But information systems now allow us to have information more easily in real time and without using doctors' time or healthcare professionals' time. without wearing them out? Well, we have a certain number of assessment missions at the French Health Authority. We have to assess the actual healthcare establishment itself. We are more and more patient-focused. We're focusing more on patient safety and professional practice. And there are a certain number of indicators. We are working on these new indicators, which are quality indicators, but increasingly they're becoming practical indicators and professional practice. Often doctors considered that our indicators were too technical and were not linked to real life. So increasingly, we are going to be working with medical practice indicators and especially patient safety indicators. Maybe not fast enough. Again, the English-speaking countries are way ahead of us. They've already set up indicators, morbidity indicators, but also the mortality indicator, which is quite notorious, which is a ratio of intra-hospital mortality, standardized. And it's taken us time to implement this in France. It's not so simple. Obviously, there is an adjustment that needs to be made depending on the seriousness of the cases, comorbidities, and the age of the patient, and that's difficult. And then the experience of other countries has shown us that these indicators lead to biases sometimes. The first bias is the problem of the codes. It's not completely perfect. But the other biases can be linked to the fact that you select patients. People start to select patients to decrease the standardized mortality rate. And the third bias could be that you actually release patients. So we want to be sure that the indicators that we use, that we are currently developing, have been fully validated before we put them into application. If we have the time later on, I'll come back to these indicators to discuss their usage. There are two types of usage: internally for the healthcare establishment to improve itself, and externally to inform the patients, the users, of the results in the different healthcare establishments and with the different teams. Xavier, you mentioned two words that were abundantly mentioned this morning. You said that we ended up in going back to the patient's record. So we see the difficulty here of having a legible patient's record that's easy to use. Seems that we're going in circles, in a sense. And you also said that we should try to remove a certain number of taboos to understand why healthcare professionals are so reluctant. Why is there this taboo surrounding assessment? And probably the taboo and the difficulty of implementing the patient's generalized medical record, perhaps there's a link between this reluctance to be evaluated as well. Jean-Luc said clearly that assessment should be specific. It should depend on medical practice and specialties. What can be the role of a knowledge society or a professional society? You can't evaluate a doctor the way you evaluate any other medical practice. Well, I think there should be criteria. Indeed, there are certain areas of medicine, for example, surgery, that are quite easy to assess. Surgery, there are indicators that can be all across the specialties, and not only quantitative, as is too often the case, but more qualitative in terms of the outcomes. And here, indeed, these indicators that can be transfusion rate, recovery, or repeat operations, or mortality rates, these all exist in the computer databases. The authorities have them, but they're not always communicated. It's not always easy to exploit them, or there's a problem of organization. But there is already a lot of data. There are many indicators that are already objective, that are fairly reliable. And this is linked to what you were saying. It's essential that the professional societies work with us. And I think for each specialty, for each discipline, we could choose 2, 3, or 4 of the most frequent pathologies, and then the professional societies could give their opinion on the criteria, which could be relatively reliable. Of course, all criteria can be criticized, and we know that some of them can be reliable nevertheless. And I think we need to associate the opinion of the patients also to integrate these criteria concerning quality of life, not just post-op qualitative criteria, but also quality of life follow-up. So I think working with an institution that would be in charge of defining the criteria, associating patients' associations and doctors' associations. And once we do that, I think we can then put it into a database and then decide what we do with it. That's another topic. Sir Took, perhaps you can answer this right away. These indicators, should they be, we saw this earlier concerning the pharmaceutical record or the medical record, should it be exhaustive, complete, or do we know that perhaps 4 or 5 indicators are linked to the others? Should we be exhaustive? Well, once again, I think if we put too much information in, it will kill the information. We need to choose reliable criteria. There will be trans-specialty criteria that, for example, for all types of surgery, and then for each specific discipline, there will be a specific criteria, such as in oncology, survival rates, and these are simple criteria. I don't think we should look for criteria that are too complex. I absolutely agree. I think we need to limit them, the number, and limit them to simple criteria. There's one that becomes a major criterion, which is the patient satisfaction rate. Patient satisfaction. That's indispensable. The way in which the patient has perceived his treatment. You know that in some healthcare establishments we've set up what we call the patient tracer, and we follow the patient as the patient moves around through the establishment. And we, from the DGOS, we were entrusted with a mission to develop this patient satisfaction indicator called ISATIS in French. It's now operational in every healthcare establishment for all patients who have an internet connection, because it is via the web. And the question that we're going to ask at the end of September is to decide whether we publish it at the end of this year or next year.
Yeah, if I could add to that, I agree that the patient experience or patient satisfaction is a critical part of the assessment. We can conceive of quality as a measurement of the defined outcome, the achievement of safety, but fundamentally it's about the total patient experience. And one of the things that our General Medical Council, the regulatory body in the UK, has done in setting up a process of revalidation of every medical practitioner every 5 years. That process involves a 360-degree patient survey, so that how patients perceive you is very much taken into account. It also takes into account a 360-degree appraisal of how your colleagues, both those you work with and report to, and those that are your leaders and managers, perceive you as well. And I think this is an incredibly important part of this. It's not simply about skills, it is about behaviours and how you relate to the rest of your healthcare team. That can be lost if you just focus on your own skill competency. You can still be part of a dysfunctional team and damage the overall outcome unless that particular facet is attended to.
Je vais donner la parole à Jean sur ce sujet plus particulier, mais
yes, we will come back to that particular topic. It is indeed important, because we could imagine that when we implement these criteria, these indicators, that we might have a very technically oriented assessment, whereas the patient's judgment, their feeling of how they were treated, this will take into account the fact that my doctor's a nice guy. He's got some charisma. So when we're doctors, we receive a phone call saying, even our friends call us and say, do you know a nice dentist? And we know that he's a good dentist, but patients want him to be a nice one too. It's a bit more complicated than that, we must add. Yes, I'm being a journalist here. I'm simplifying a bit.
I think there are two aspects we need to clearly differentiate, and one is patient experience, and patient experience includes a lot of very important and valuable information. For example, did I receive the right amount of information? Did I really know how to proceed in my treatment at home? Did the doctor spend enough time with me to explain, relevant stuff to me? These kind of things are extremely important. some people mix it up and say patient experience is all about the food and the cleanliness of the room and the friendliness of the porter. And we should be careful. There are a few things that are not at all correlated to overall care quality. I mean, you might measure them because you want to inform the cook about the quality of his food, but that has nothing to do with driving improvement of healthcare delivery. Apart from that whole piece of patient experience, there is the area of outcomes, and within outcomes there is a field of patient-reported outcomes. And this is something I believe is essential, because when we talk about patient-reported outcomes, then we are somehow entering a completely new level of information. So explain that to me. We have quite a lot of outcome information today in electronic files. You can probably, find in your computer systems if the patient has had a severe blood loss during surgery, if there was an infection afterwards. You will get information about reoperations and all these kind of things. And this is important information, but we can collect this information without even asking patients. Healthcare is getting exciting when you take into account the perspective of the patient. So, for example, if you ask a patient who has received a heart surgery half a year later, what about your quality of life? What about climbing the stairs? What about walking the dog, which was so important for you? How about your sleeplessness in the night? Is there pain that is troubling you? What about, your working abilities? These kind of questions are the most important ones, and these are finally the ones how patients judge correctly if a medical intervention has been good or not. So, and that's actually the area where a lot of, doctors on the one hand are very, very scared about. They say, oh my God, I tried to be a good surgeon for many, many years, and now they are asking my patients how good their partnership life is. Is this fair? So this is a completely new dimension of questions. On the other hand, and that's very, very good to know, every doctor is interested into that. Doctors desperately want this information. If you ask 100 surgeons, do you like the idea that I provide you with reliable, statistically correct data about the quality of life of your patients 6 months after you have spent 8 hours in the OR to make this guy happy? Then they say, I want that.
Xavier, tu voulais intervenir. Vous intervenez quand vous
La
voulez.
qualité de vie, l'appréhension des patients, nous avions il y a une dizaine d'années.
Yes, 10 years ago, talking about patient assessment, we set up a system to assess by the patients. They entered it in their own computer, the results on the biological results, and also the information on the quality of life, so post-op results. We had less information than we'd hoped, but at least we had the truth. And we had about 700 to 800 patients. For technical and administrative reasons, we were limited to that number. But we continued with a questionnaire that patients filled out on the quality of life. But they didn't fill it out in the doctor's office or in the waiting room. No, they didn't see the white coat, the doctor's white coat, because they'll never tell the doctor that things aren't so great. And they're a bit afraid to tell the truth to the doctor. No, these were filled out at home, questionnaires that were validated that were international on the quality of life. And then we enter it into a database, and we have information that's extremely precious that allows us to adapt our practice. Yes, I wanted to comment on one thing, 2 points. The first is that we can integrate from an institutional standpoint the experience, the patient's experience. But after that, you'll always have the civil society who will come in with applications, with internet that will challenge us here. So that was the first point. I'd like to react to what you were saying right now. In this, between the doctor and the patient, when they're alone together, this discussion, it's difficult to have a real assessment. By definition, this special discussion or conversation only concerns the patient or the doctor. So to have an outside tool is something that's extremely disturbing for professionals. You've said this very well. the patient overall won't necessarily dare say that he didn't understand something that the doctor explained in taking his treatment, how to regulate his treatment, if he needs to take a half a pill less per week. And he won't dare tell the doctor that. So I think assessments on the smartphone or via the net or directly integrated in the healthcare institution does provide an indispensable added value to be able to optimize patient care and to be more attentive to the patients and to make sure that the professionals are more attentive. I think we tend to be very self-centric among healthcare professionals, and it does open us up a bit. I will give you the floor, Jean-Luc. I just also wanted to say that it could be a good experience in hospitals. We have inside the hospital, inside my hospital, we had 2 or 3 accreditation and certification procedures, and the experience I've had as being in charge of it at the time was that the preparation period before the visit of the experts and before the assessment is a fabulous moment for cohesion of the team, the healthcare team, whether it's the medical or the administrative or the paramedical professionals. It's at that time there's a real project, and it's true that once the experts have left, gone through, everyone says, oof, a sigh of relief, and then things kind of fall back to the old habits. How could we ensure in these hospital structures, institutions, and perhaps also with individuals, how can we make sure that these assessments would remain sort of an encouragement, a permanent encouragement? Jean-Luc?
Before I answer that question, I'd like to come back to the one-to-one relationship between doctor and patients, because I think it's becoming less and less that now. If you take the example of surgery, surgical mistakes are obviously what the surgeon experiences during the procedure, but it's also the indication, which is not always only made by the surgeon, and the post-operative period with all the people who come along and contribute to the operation. So it's a team, a surgical team. And in cancerology, it's not necessarily my doctor who decides. It's a decision that's made together. So patient management is something that is done by one doctor, perhaps, but it's increasingly by a team now. To answer the question now, I think we've got to a very important point. The issue is evaluation, but what for? You may make an evaluation to make an individual decision if you're a doctor. That's what we call recertification, credentialization, privileging, and so on. These are all ways of making assessments, and they lead to decisions. And at the end of the day, they may lead to the accreditation of hospitals. So that's the first way of using assessment and indicators. It's to take decisions concerning individual people or hospitals. The HAS, the French health authority that I represent here today, doesn't have the power to monitor or sanction. And we believe far more into other ways of using assessment, which are, first of all, getting the health professionals and their teams to become involved in progress to be made, to avoid side effects or undesired events, to avoid them happening again. And we monitor the results of the methods we use. That's the usual method we use to improve the quality of the care that we give. And it has to be done in a team to the extent that is possible. Meetings for morbid mortality, feedback on experience, and so on. I think that the use of indicators should be this. We have to have multidisciplinary teams who can use their experience, analyze it, and improve by comparing with the existing data. And that enables me to end with the second advantage in my sense, which is benchmarking. I do believe in publishing results to inform the patients better to start with, that's obvious, but also to stimulate and uplift the health care establishments. And we have a system which is used by the healthcare professionals and the users, which is called Health Scope, Scope Santé. And I think that's something that we're going to have to push even further still. And we also have satisfaction indicators that we're going to put on the site later. I think we need to publish indicators of results, which will enable the patients to make a choice. But it'll also enable the healthcare establishments to position themselves. You wanted to chip in.
What happens in the UK in terms of assessment of institutions? So we have something called the Care Quality Commission to avoid this issue that you prepare for the visit and then things go back to normal. They could also make unannounced visits, which you could imagine puts the institution on the spot. These are extensive visits. They can involve 30 people and take several weeks. And because of our highly politicized health system, a national health system, the consequences of their decisions can be far-reaching, often, in my view, to the detriment, because they're very judgmental rather than formative, and actually, I think, have resulted in more rapid turnover of the leaders within an institution, despite the fact that we know that a determinant of hospital quality is consistency of leadership.
On est dans les effets pervers. We are in the perverse effects of this evaluation. Go ahead, if you want to.
No, so I think the major point here is that all assessments, be they of individuals or of institutions, need to be more formative. They need to be geared towards ownership of the process and continual quality improvement rather than the guillotine approach.
James, if you can just comment on that, les effets positifs, les effets d'engagement d'une équipe sur l'évaluation.
The effects of having a committed team, a consistent team, and the adverse effects that John has just mentioned. He's a head of department, and heads of departments very often leave because they're fed up with being assessed.
That there are, I've seen that there are different phases you go through as a team, or maybe even as a society or country. So if you start, measuring care results in what way, and you start to discuss making them public, there's always a lot of anxiety and fear. And of course, people typically react awkward when they are anxious. But my impression or my experience is it is important to make it a normality very, very fast. So once you are through the second and third round of evaluations and you provide continuous data, meaningful data on quality, there will be some discussions about data quality, about correctness, about indicators they use, and also around risk adjustment. But believe me, that has been done around the world 1,000 times, and that's somehow doable. But what I see then is that the care teams use these data in a very, very systematic and very professional way. So there is not discussing about the if and the how. It's, okay, what can we learn from that? How can we get better? There is someone who has achieved better outcomes in this and that dimension. Who is it? Is it John? Is it Jack? Is it Jim? Is it another hospital? Can I go there? Are they ready to share data? So we have to make that a part of the medical culture. We have to introduce this perspective, the patient perspective, into the normal workflow. And then we will see that at this level is no problem anymore. Maybe let me add one other aspect. People typically overestimate the effect of transparency to the public. So we have seen in many, many countries that a lot of sometimes exciting informations are available. Look at the Swedish registries, who are, at some levels publish very, very highly delicate data to the public. Look what is happening in the NHS England. Outcomes, complication rates down to the individual surgeon level. I can go in the internet, find my personal surgeon's name and the complications of the last couple of months. So this is all happening today. And you have never seen a revolution or suicides or other catastrophes. What you typically see is the public is interested in a very, very, let's say, condensed form of information that drives decision. And if they are not provided with it, they typically don't care so much. And the care providers are interested into details.
Merci, Michael.
J'aimerais rebondir là-dessus en reprenant mon petit exemple sur l'utilisation des résultats, en prenant mon petit exemple de la formation théorique des internes qu'on avait lancée. Donc,
we launched in 2014. We launched a program for the residents to assess their performance, and there were two types of reaction. The first was that we got the residents to come to the dean's office or to the head of department. I won't give any names, feel reassured. Their reactions, not all the reactions are on the internet. And there were two types of reaction. It was, okay, we'll go to the meeting. We're not well classified. We'll have a meeting with the deans and see how we can improve the way we deal with our residents. And secondly, there was an evaluation of the training courses they did, and I rather wonder why this isn't part of the certification program in the hospitals. Why don't we take a look at how the hospitals do this to improve the way they deal with their young professionals? As far as evaluating training courses are concerned, we have to assess the teaching courses we give. It's a legal requirement. So it's a legal requirement. In France, we do things properly. We take a paper. We assess the residents assess their trainers. That's to say, the teaching they've been given. And with that piece of paper, most of the faculties and medical schools keep the piece of paper and pile them up. And they just don't use them. It's a gold mine, and we don't use it. And they're beginning to have applications now, which you can put directly on your smartphone, and you can tell them whether you think the residents' work is important, whether they're properly trained or not. And there are lots of things you can do to improve the training we give to our young professionals. Well, to bounce back to the subject of teaching, on training, I think that one of the goals of training is to improve the training courses we give to our doctors. And you can always use all the new possibilities. Last week, we had the first MOOCs on ambulatory surgery in Paris, with all the simulation technologies that are completely changing the quality of the teaching we give to our doctors in relation to what we went through 25 years ago. And the second thing is that on certification and training the trainees when they go on training courses, we have training courses that have goals, and these goals are assessed by the residents. They assess the teaching course they've been given, and I think that if they don't fulfill the function they're supposed to, they're reassessed 2 years later, and if they don't comply second time round, then they're not considered as trainers anymore. Perhaps John could say a few words here, because the system exists. The accountability of the teachers in radiology in France is a good example. We went to see the Royal College of Radiology, and we discovered the visits, the certification visits they do with the teaching to assess the teaching programs, and there were sanctions if the teaching program was clearly not there. But today, when you're a professor or a teacher, you're a teacher for life. And even sometimes even a long time after your life. John, over to you.
Important that right from the get-go, undergraduate medical education needs to be encouraging reflective practice, because essentially that's the mindset that underpins all of this continual improvement based on your own behaviour outcomes, etc. And it is also a commitment to lifelong learning. We all know, those of us in medical practice, that the knowledge that we now use in our daily practice is nothing like that which existed when we graduated. And so unless we build in a commitment to lifelong learning and reflective practice from day one, we won't have a medical profession that evolves to take advantage of the new developments. And we've heard already today just how an understanding of quantitative skills, informatics and so on will play a huge part in the future of all healthcare professionals. So I think early adoption of the right learning culture and getting away from the idea that students and young doctors are passive vessels to be filled with knowledge is a very, very important cultural aspect.
Nice metaphor. Thank you. Maintenant, on va faire un petit peu de politique, parce que ça sert à rien si on change rien. Cham, comme objectif de changer.
Very good metaphor. Sham's goal is to change the world. You know that, of course. Now, this is probably something that we're going to do at a new roundtable this evening after the aperitif. But we've still got 10 minutes left, so that's 2 minutes each. And we've all said that, in point of fact, assessments everywhere. It's in the magazines. The hospitals compare themselves to others. And we're very happy when we're at the head of the classification. Not quite so happy when we get to the tail end. And the faculties, although they don't say this, talk to each other. The students know very well what the success rate in this, that, or the other faculty is. And I know friends who've rented studios near a very good faculty so that their children could go there. So that's what evaluation's all about. It's present everywhere. And you said that everything's on the internet because there are applications to assess training courses. However, people are very reluctant to setting up these evaluation systems. We were talking about how reluctant our colleagues, the professors of radiology, were to have the training mock-ups assessed. And there's no structure because the knowledgeable societies just don't do that. Now, I'd like to use the last few minutes to say first what the diagnosis you make is, why people are reluctant, and how you're going to raise these barriers. A minute and a half each. Who wants to start? Youngsters do politics really well. Go on, over to you.
So, do they have kind of empty rhetoric already up their sleeve? No. No, I don't have any rhetoric. No, sorry. No, obviously there is a lot of reluctance. Some of it is cultural. When I was talking about the guillotine, that's what it's all about. You know, right at the start, you know, we're assessed and we're sanctioned. And so we've got to get over that taboo. I remember having a discussion with my dean at the time saying, well, you know, what has to be done for students to succeed better? And the students say more assessments. So instead of having an assessment every year, they want for assessments that are continuous assessments so that they can continue to improve their performance on a regular basis when it comes to medicine. So we've got to get beyond that taboo. It's complicated to do so, but I think we're going to manage to do it, and we're here to change the world after all. Yes. So there is this reluctance, and it comes from the risk of being stigmatized, the risk that may be legal. At the HAS, we have a very different vision at the High Health Authority. We are developing a quality-based culture, a teamwork-based culture, and I've insisted on this importance of teamwork. That's why we have team accreditations, single-discipline team accreditations. We're working also on multidisciplinary teams. We've got a PACT program. And what we believe is that together, without, trying to stigmatize people, we want to have an alert system, a warning system, based on indicators so that we can really analyze things and make progress. We believe a lot more in this than in punishment, in sanctions. So I agree with my colleague in that respect. We need to get beyond that taboo. We're not here to cut off heads. We're here to work together and make progress together. Now, if you allow me an extra 30 seconds, we may not fight against progress and the desire to publish assessments everywhere. A few years ago, there were weekly publications focusing on the quality of clinics and hospitals with a ranking system. Because the problem is with the ranking system, it means that, you've got pricing as well. We don't do rankings. We do complete assessments of clinics and hospitals. But things have gone further now. There's a user site called Hospitalité. You were talking about TripAdvisor in the United States and Sir John Card, where surgeons are judged. We cannot fight against that. There is a natural tendency to classify everything, to rank everything, to make everything public. Now, obviously, we can't oppose that, but we need to be able to provide an alternative solution based on assessment, based on validated, complete and upgradable criteria. And the professionals need to talk about this so that people don't do it instead of them. Yes, Xavier, we've been talking about assessments. And there's another annual event, and that is the World Rugby Cup. Today, the French players, like the All Blacks and the Springboks, they are fitted with little sensors in their tops. They wear them throughout the World Cup to assess their performance, their impacts, their accelerations, and they do it individually and collectively. So we need to see it as something that is positive, that's going to improve the situation. Let's hope that France beats England. Yes. And one last thing, just to say that concerning publications, the key is really to take data out of silos, make sure that everything is disseminated, integrate quality criteria, make sure that academic societies are involved, and of course we need political willpower as well. Sorry, Xavier. This round table was on schedule, but anyway, let's hand over to James.
I believe that what separates doctors from most other professions is that they are highly competitive by nature. They are competing at school, they are competing at university, they are competing for the best grades, for the best positions, whatever. So we must not forget that. And this is a very positive aspect, they are striving for excellence. Every doctor wants to be great. If you put 100 doctors in a room and you tell them, we have done an assessment and you are all average, you have a problem. I promise you, you have a terrible problem. This is completely different if you put 100 plumbers or teachers or whatever in a room. So they are striving for excellence. And because they are lacking data, today, most of them feel comfortable by pretending to be great. I am great because I'm a professor. I am great because I've been trained in France. I am great because I've been trained at this university. I am great because I have seen so many patients, because I have this and that facility. I use this and that technology. Everybody tries desperately to find good arguments why he or she is great. If we put the right data on the table, and the right data are simply the results that matter to our patients, doctors will strive for excellence and everybody will benefit.
Thank you, James. John, welcome in France. You have 2 minutes for a conclusion.
Okay. So just attending to the question of reluctance, I think there are some understandable and some poor reasons. Professional bodies can operate as guilds and deny advance, and so at their worst they can stand in the way of this sort of progress, but at their best they can accept and adopt it and ensure that their members fully engage, because I agree with Jens that it's critically important that this is owned by the profession and that peer pressure is a far more potent way of introducing this than some top-down control mechanism. And indeed, it's that top-down control, that concern that the regulator will create scapegoats, that is at risk of denying innovation and denying the fact that medicine by its very nature is always a balance between risk and benefit. So you get hammered if you don't accrue the benefit, the desired outcome. But how often do you hear a regulator being strung up because they've actually denied the opportunity to take an innovative step? Whereas that's what the medical profession do over the years. They've actually pushed the boundaries of what's possible. That's risky and may not fall into this same sort of paradigm we're describing. So don't let's stifle innovation in this appropriate desire to see proper assessment.
Merci à tous les orateurs. Je voudrais
Thank you to all of the speakers. Before we have to go to lunch, before we have applause, can I thank Guy Valencien for his excellent organization. Again, this panel discussion was fantastic. Thank you to all of you and enjoy lunch.